Hello, everybody. Welcome to my monthly webinar. Today, we're going to talk about peptides and some peptide stacks. Got a small group tonight, so if you have any questions, just you can even keep unmuted and just ask away. Hello, Wilson. Where are you located?
First of all, I'm not sure my microphone's working. Can you hear me all right?
I got you.
Okay, so I'm located in Northern California, Sacramento area.
Okay.
Although I do know quite a few chiropractors in the Texas area. I lived in Houston. I actually got trained in AK at Texas Chiropractic College under
All right.
Rob Rukowski.
Very cool. All right. I'm a Northern California guy originally, went to UC Davis, wrestled there, and I've been out in Texas now for about 12 years. So.
Well, I used to coach the pole vaulters at UC Davis.
Oh, really? Oh, yeah, very cool.
Yeah.
Small world.
1979.
Amazing. All right. That's awesome. Well, thanks so much for joining me. I'm going to switch over to my presentation and we'll get going.
Sounds great.
All right. So tonight we're talking kind of about popular peptide stacks and what I use in the clinic. Again, my name's Ed Cara. I have a PhD in sports medicine. I'm also a chiropractor, a family nurse practitioner, licensed athletic trainer, and a strength and conditioning coach. So I've kind of done a lot of different things. I currently own a clinic in Dallas, Texas. We do functional medicine and rehabilitation, and it's called Body Lounge Park Cities. If you're watching this on YouTube or from my channel, just and you want to get in touch with me, I'm pretty easy to get in touch with. Just either scan the QR code, send me an email, call my clinic. I'm happy to help any way that I can. But how we're going to start off tonight, I kind of want to know, Wilson, are you currently using peptides? Are you just getting some information? Where are you kind of at right now? I think
Sorry,
there you go.
I muted myself. Yeah, I've been on tirzepatide for a couple months.
Oh, okay, great. Okay. Yeah, we use tirzepatide a lot. Works very well. How's your experience been so far?
So far, it's been very positive, although I'm now at the point where every time I lose a half pound, the alarms start going off because I'm at that point where I think I need to start building up some more muscle and stuff like that, you know.
Yeah, sure.
And I've taken some action on that and, you know, changed my exercise around. I'm starting to eat more and stuff like that.
All right, that's good. You want to maintain high protein diet on any of the GLPs. High protein to me is about 0.8 grams of protein for every lean pound of body mass. So pretty good amount. And evenly distributed through the day. And then at least 2 to 3 days of heavy weightlifting, whether that's compound lifting or isolated lifting. I use a lot of computerized resistance or blood flow restriction training, but we want to get that heavy weightlifting in to stimulate that protein synthesis. So great. So what is a peptide? Most people don't even realize that we make our own peptides. That one of the most famous peptides that we create is insulin is a peptide that is released in the presence of blood sugar, and it helps to pull sugar into the cells. So peptides are just small proteins made up of amino acids. And when I say small proteins, they're less than 50 amino acids in a chain, whereas proteins 51 are larger or more amino acids in a chain. And they're just these little signaling molecules. And they can be distributed different ways. They can be either nasal, they can be injectable, they can be cream or topical. Most of them are compounded at this point, although some of them are made by Eli Lilly and some other companies. But most of the time, we're getting these from compounding pharmacies, and we want to get them from reputable pharmacies for sure. So when we're talking about stacks, a lot of people will know just from social media or from talking to their friends about these different types of stacks, but the stack names are not medical terms. So if you hear like a Wolverine stack, which we'll talk tonight about, or a glow stack, that's a marketing term and not a standardized diagnosis. The FDA has some specific safety concerns, and they're still trying to work through what are they going to approve. There's 14 peptides currently kind of on the panel right now that are looking to get voted in to be able to be compounded more regularly versus more on the gray market, which is where we're seeing them used mostly now. But most peptides are not FDA approved because they don't have a lot of long-term scientific data for safety in the United States. But a lot of them have been used in other countries like Germany and Russia and Europe for decades. A lot of them we've been making ourselves, like our gastric juice makes BPC 157, one of those in the Wolverine stack. And so we make a lot of our own. We're just signaling to create more of our own making. So a lot of times we're not even injecting foreign substances in. We're just signaling to our own body to create more. And as we age, we don't create as much. And so this helps to signal more. So like, for example, if I want to signal more growth hormone, because as we age, we release less growth hormone than we did when we were young, then we would use a peptide to do that. And we would use a specific peptide based on what we're trying to achieve. So if we're trying to achieve more recovery, then we might use something like ipamorelin. If we want to use something for sleep, then we might use something like CJC with ipamorelin. So it just depends on what we're trying to accomplish, is really what kind of peptide or what peptide we will recommend. So what is your primary interest in peptide therapy? Is it recovery from injury or surgery? Is it weight loss or body composition, anti-aging, skin, longevity? Or is it energy, sleep, or hormonal health? You can just put it into your chat. But Wilson, you can just tell me, what's your big interest right now with peptides?
Well, my age management guy put me on it because my A1C it was persistently at about 5.9.
Okay. All right. So you're pre-diabetic. And so, yeah, using the peptide versus like a metformin to get your A1C down. And that's where we're seeing a lot of peptides being used, is before we get to the medication, using a peptide to help us get to where we want to be. And I see the same thing with using either tirzepatide or semaglutide or retatrutide, any of the GLPs. Really a really amazing improvement in triglycerides, in hemoglobin A1C, in insulin fasted, in insulin or glucose fasted, cholesterol levels dropping, like lots of nice markers reduction when we do our post follow-up labs. What I kind of do at Body Lounge is somebody comes in, like today I probably did 3 different peptide consults. I ask first, what is your goal? Like, what are you looking for from the peptide? What are you trying to optimize? What are you trying to do? Is it just general health? Is it longevity? Is it weight loss? Is it hormones? And then we work backwards because there's so many different peptides. I have access to about 150 different peptides, and a lot of them do a lot of the same things. So how we pick and choose is really based on the individual. What are they currently taking medication-wise? What are there any comorbidities? What are the health concerns, other medications that they're on? So really everybody gets individualized approaches, which is really how it should be. So kind of going into some of these stacks, like a healing and recovery stacks, you'll hear terms like the Wolverine stack, which is BPC 157 with TB 500. These can be done individually, where you have a vial of BPC and a vial of TB 500, or you can get them combined, which is how I do it, which is easier, 1 injection every day. And your dosage is based on whether you have an acute injury or you have more of a chronic injury. The Glow stack is the same, the Wolverine, but we add GHKCU, which helps then with your skin. So they call it Glow because it gives your skin kind of a nice glow. A lot of people use this. It's been very popular about the last 6 months. The Glow is something a little bit newer. It's the Glow, but then they add KPV. It helps with gut health. So we'll use this in combination. If somebody has dysbiosis or they're having gut issues, they have autoimmune conditions, things that we need to heal the gut. So that's where we use the Glow stack, or we could just use a straight gut repair stack, BPC 157 and KPV. Our growth hormone and performance stacks, we have numerous. We have a standard growth hormone stack. So instead of just injecting growth hormone in, or human growth hormone, the problem when we do that is that our brain recognizes that we have circulating growth hormone in, so it will downregulate how much our anterior pituitary releases. So instead, what we do is we pepper it with what's called a growth hormone secretagogue. Basically, it's a signaling molecule that tells our anterior pituitary to release more of your own growth hormone. So you're just releasing more versus putting more into the system so you don't downregulate your own production. The other thing that we do with these is we make sure that we're cycling them 6 or 8 weeks on, 4 to 6 to 8 weeks off. And so we cycle these so that our body doesn't get too used to them, and we're not sending increased stimulus down the same pathway over and over and over again. One of the performance stacks that a lot of people like is the CJC 1295 with ipamorelin and BPC. Sleep, ipamorelin with CJC 1295 with DSIP works very well. DSIP is delta sleep inhibitory protein. It helps you get into a deeper sleep state without having to use something like a sedative. And then visceral fat stack, tesamorelin works very nicely even by itself, but you can also add ipamorelin as well. Both of these are secretagogues. One is long acting, tesamorelin a little bit longer before you get your peak. Ipamorelin a little shorter acting. You're kind of getting a little longer half-life when you do this kind of stack. Our metabolic and fat loss stacks. So metabolic reset, we're going to either use semaglutide, tirzepatide, or retatrutide. And usually when we're compounding those, they come with either B12, mixed lipoprotein, or NAD. I don't really have a preference with any of these. I've had good success with all three of these as compounded. The reason they are compounded is because otherwise compounding pharmacies will get sued, because Eli Lilly and other companies have patents on their retatrutide, they have patents on their tirzepatide, they have patents on their semaglutide. So you'll see this compounded, which is fine, still works just as well. We're still using the same amount of semaglutide or the same amount of tirzepatide as you would see like in a Wegovy or a Ozempic. Metabolic core, MOTS-C. MOTS-C is a peptide that they say is like exercise in a bottle. So you're basically stimulating your own mitochondrial production like exercise, plus NAD is nice. 5-amino 1-MQ decreases fat storage. So it attacks your fat, especially fat around the lower abdomen. Body recomposition, AOD 9064. That also kind of stimulates your fat loss. So we do that in conjunction with ipamorelin and CJC for body recomposition. And then GLP support with protein and resistance training to try to preserve your muscle mass. So we use GLP with, let's say, like I might use that with an IGF, insulin growth factor, to help stimulate muscle mass while you're on a GLP if you're having trouble maintaining your muscle mass. So you personally, Wilson, have been using the GLP-1 like tirzepatide, and it sounds like you've been having good success without any side effects, yes?
Yeah, that's correct.
Yeah, that's great. So did you start kind of at like a 2.5 milligrams per week and you just gradually built up from there? You've been pretty low on your dosing.
I've stayed pretty low. I forgot the math, but on that tuberculin syringe, I was up to 20 units at one point, and I've actually decreased it down to 18.
Okay. All right. Yeah. So usually those are going to be, our tirzepatide comes in 30 milligram with 2 mLs of bacteriostatic, so 15 milligrams per ml. So, and that's a good point, is that depending on the concentration and how it is reconstituted will affect it. So I like to always use milligrams when I'm talking about my peptides, because otherwise it gets very confusing. Because if we talk about units, depending on the concentration, depending on how it's been ordered, it could be very different. So just being consistent with our terminology is important to make sure we're using safe doses. And of course, like if you think you're only using 2.5 milligrams of tirzepatide, you end up using 10 milligrams of tirzepatide. It's a big difference, and it can easily cause nausea and diarrhea and other side effects.
Sure. I believe my initial 2.5 milligram dose was like 8.6 units on that.
Okay. All right. Sounds good. Longevity and mitochondrial stacks. Here we're looking at NAD with epitathlon. I like epitathlon about twice a year for just for our mitochondria health. And then you can also use thymosin alpha-1. Thymosin alpha-1 is a nice anti-inflammatory. I use it for rheumatoid arthritis and other inflammatory arthritis or autoimmune. So the thymosin alpha is really nice. So this longevity foundation is good. NAD can be used ongoing because it's really working at the cellular level. So once those cells die, new cells are born. So you don't really have to you don't have to really cycle it. NAD can be used all the time. Really, really nice peptide. Mitochondrial stack, we mentioned this, the MOTS-C with SS31. SS31 is a nice anti-inflammatory, and really that can help with fatigue and energy. Cellular repair, we've talked about the NAD before, the GHKCU, that's the copper peptide that we use for skin. And then again, the thymosin alpha-1. And then your senolytic protocols with fisetin and FOXO4. FOXO4 is basically, it clears out your zombie cells, or these cells that are not really active. They should be dying, but they're not quite dying, and you want to get rid of them and clear them out, like almost detox them out. So that's what the FOXO4 is used for, and the fisetin is used for as well. For skin, hair, and aesthetic stacks, the glow stack's super popular right now. Like I mentioned, that's the GHKCU, the copper peptide, plus BPC 157 and the TB 500. The skin and hair stack, GHKCU, and then you can also add on top of those either collagen peptides like that we ingest. Some really good research done at UC Davis in their lab there, Dr. Bear, where he was using collagen peptides ingestible with vitamin C prior to exercise for tendon regeneration and tendon regrowth. So I use that a lot. I use a lot of his research for my dosing for patients recovering from tendinopathies and tendonitis. And then beauty repair stacks, GHKCU plus NAD, and you can add or subtract BPC 157 with that. These are getting super popular right now. I'm getting asked a lot about these, so people don't have to use as much Adderall or Ritalin or some SSRIs. So Semax and Selenk, these are used as needed. So like I'll use Selenk for patients that are having a little bit of anxiety at times. This can be used as intranasal. Hard to find right now. I'm having a tough time getting it intranasally, but injectable, still very easy to get. Semax is more of like your cognitive focus, almost like your Adderall. So we can use either one of these as a PRN, just as needed. Learning and memory, Cmax and dihexa. Dihexa is a nootropic. It's almost like using a low dose mushroom. So we use this to help with our cognitive function. And then your calm focus stack, Selenk, plus like a dihexa or a mushroom, something like that, very light, low dose. Sexual health and hormone stacks. So for the libido stack, PT141 works very well. You can use it just as needed, almost like I would use like a Cialis, or primarily I use tadalafil, Cialis. And that also helps with some hormone optimization. HPG axis stack, we can use kisspeptin and gonadotropin. These are going to help with testosterone, your own testosterone production, without having to use actual HRT. I use HRT a lot with patients. This isn't going to move the needle from like 200 testosterone to 800 testosterone. So instead I'll use pellets primarily. And then your testosterone support also with kisspeptin and the gonadotropin, so the same. So not all peptides are created equally. Some of them are FDA approved. Some of them we're still looking for approval. There's a lot with human clinical data, but a lot are just rat data. So we've got to take it kind of with a grain of salt with what you're getting and what you're using, and having an open conversation with your provider. There's limited human data, but a lot of rat data on BPC 157, TB 500, NAD, thymosin alpha. Again, a lot of studies done in Europe and in Russia for a long time on safety and efficacy. Preclinical only right now. We're seeing this also with retatrutide, another GLP, although we are able to get it, but it is considered evident research only right now. And then anecdotal, the computer reports, we don't know any systematic data. So again, every patient's different, so we want to make sure that we're meeting their goals. We're rotating these, so we're not hitting the same pathway over and over and over again. But really, we need to make sure that the sleep is intact, you're getting good recovery, you're exercising efficiently. We're doing high-intensity interval training. We're doing heavy weightlifting. We're doing recovery methods. We're keeping our cortisol level down. We're keeping our sugar level down, alcohol levels down. And really, peptides should be like a cherry on top, except for when we're using it in replacement for medications like a tirzepatide. But some of these other ones, without really having our hormones in place, our diet, exercise, all those things, we're not going to get nearly as good of results. So before today, Wilson, did you know which peptides had FDA approval and which were kind of still experimental?
Oh, I had no idea.
Yeah, most people don't. So that's why we just want to have a good conversation around that. What stacks I don't recommend doing casually. I don't think GLPs should be stacked. I just wrote a big white paper. 50 some odd % of patients that start a GLP will get off of their GLP within 3 months prior to getting to their goal weight or lab results that they're looking for, mostly because of side effects. So it means that the dosing is not right. or they're not using the right. We want to try to avoid using multi-mitochondrial agents. So we don't want to use these all at the same time. I see some patients come in, they want to do a consultation and they are using 10 peptides. And I highly recommend against that. It's really hard to know if we're having any side effects, which ones are doing it. If we're having good benefits, we don't know which ones are doing it when we're stacking all of these. So I try to use 2, maybe 3 max at a time. And then definitely don't want to be using growth hormone secretagogues or analogs without testing and doing lab work first, measuring your IGF, knowing where those levels are before we start peppering your anterior pituitary with more. I'm also getting a lot of adolescents coming in and wanting to get on these to increase their growth. And so we got to be careful with those as well. We don't have any long-term data on that. And so we just got to be careful with how we're stimulating your own growth hormone to be released. So 6 rules for smarter peptide stacking. Start with a goal, not just wanting to use a specific stack. Introduce one compound at a time that has a specific measurable result. Know what's in every product you take. Don't buy stuff off the internet that you're not sure of where it's coming from. More is not better. A focused 2 to 3 compound protocol is much safer and more measurable than a 7 compound stack. Use appropriate lab monitoring. We're going to rerun labs intermittently to make sure everything is safe and we're not causing inflammation and other markers. And then your source matters, making sure that we're getting it from a safe manufacturer or compounding pharmacy. So 5 questions to ask any peptide provider. Where does this peptide sit on the evidence spectrum? What lab should I have before starting? Where is this peptide sourced from? What are the known side effects and who shouldn't take this? And how will we know if it's working? When will we stop? So that way you know that there's a plan in place when we start any type of peptide or medication. Some red flags in peptide marketing that you should be aware of. Clinically proven, or saying that they're clinically proven without specifying which trial or population. Specific dosing advice given online without medical evaluation. Packages sold without prescription or provider involvement. No side effects claimed for any injectable compound. There's always a side effect. They might not be bad side effects, they just are expected. That's different versus an adverse event. An adverse event means something like an anaphylaxis or something that we don't expect. So we need to know both. What are our risks for both? Some green flags, things that we should just be aware of: provider orders, baseline labs, and before starting any protocols. That's good standard of practice. Transparent about evidence tier, acknowledges what we don't know. Uses a licensed compounding pharmacy or manufacturer with certificate of analysis, and has a defined goal, timeline, and follow-up plan for your protocol. So last poll before we wrap up. After today's webinar, what's your most likely next step? Do some more research before deciding anything. Talk to my current provider about what I learned today. I'm not interested in peptide therapy at this time, or maybe doing some other peptide. What do you think, Wilson?
Oh, and I just came to learn more about stuff.
Yeah, that's good.
I will I'll do more research before deciding anything.
Yeah, all right, great. And so again, think about what your goals are, and then if there's things to help optimize your health, then you can have a conversation with your provider on how to try to match that peptide with that health goal. And if you have any questions, you need any help, always feel free to reach out to me. I'm pretty much always available. I'm always at the office. And here are some references that I used as part of this conversation. Any questions that I can answer for you, Wilson, before we log off?
Yeah, in one of the BFR Facebook groups, you mentioned a webinar about GLP-1, which I thought was in relationship to the BFR stuff, and I was wondering if that meeting had ever happened, or maybe whether that was this meeting that you're actually promoting.
With the BFR, that was, I think, last month. It should be on my YouTube channel. That's where I usually will replay those.
Oh, okay.
But we just talked about using BFR as a way to maintain your muscle mass, so using it as a hypertrophy stimulus.
And for those of us that are part of that BFR series, is that included in that series, or should I just go straight to your YouTube channel?
You can find it either way. I think we posted in both.
Oh, you did? Okay.
I'm pretty sure. If not, just go to my YouTube channel or send me an email and I'm happy to share a link where it's at.
Okay, great. I think I'll be able to find it.
Yeah, it's just my name, Ed LaCara, for my YouTube channel.
Mm-hmm.
All right. Well, I really appreciate you joining. It's so nice to meet you, and go Aggies.
Yeah,
So cool that you're
this
up
is a
there.
lot of fun. I missed a lot of your I missed all your live BFR ones, so it's good to be finally interact with you in real time.
Yeah, thank you. Yeah, I do one BFR per month, and then I do one peptide webinar per month, just for educational.
Got it.
All right. Thanks so much. Have a great week.
Okay, great. Thank you.
Thank you.